Welcome back to Brain Talks, a podcast that explores the hidden world of brain trauma. Today, we'll be joined by Dr. Jordi, a senior lecturer in trauma, animal science and welfare at Queen Mary's University London. Welcome, Dr. Jordi, to Brain Talks.
Hi, nice to be here.
So, to begin with, could you please tell us about your background, your research interests, and the specific areas of brain trauma that you focus on?
So I am a veterinarian by training. So I work a lot with animals, obviously, but for a long time, my interest has been working in laboratory animals as a good avenue to bring my expertise to a better good, to support the discovery of new treatments, both for animals and humans. That's why I'm in the Royal London now, where together with Queen Mary, where we drive a lot of challenging yet very important research on various aspects of traumatic injury. And for that, have developed various animals models that help us to translate and to support the discovery of new ways to hopefully improve the care and the support of patients.
Wow, that must be a really interesting field to work in. So, what really drew you to focus in this area of brain trauma and also veterinary as well?
So working on veterinary medicine, I always wanted to be a vet. I worked with large animals initially, but then I felt that it was really interesting to work with laboratory animals because our work comes from the side of improving the care and the welfare of these animals. So there is a lot that can be done to improve the care, how we monitor the animals, and how we ensure their well-being while we undertake these studies. Obviously, there is always a certain degree of intrinsic compromise in some of the models that we work with. However, part of our work is to ensure that everything is approved by law and it is ethically approved, so everything is in place. And importantly, by understanding the physiology of the animals and the anatomy of the animals, to ensure that the models and the work that we do with these models are valuable. They are useful to them, to the mean that we want to do, which is discovering new therapies for traumatic injury, but more importantly, also to make aware everybody that the care and the welfare and all the ethical and regulatory framework on the use of these animals is well established and full compliance with the current regulatory system in Europe and in the UK.
Yeah, it's very important that we consider the ethical implications of animal research. While animal models have a place in research, especially in trauma science, it's important to consider the animal's welfare. So, focusing on brain trauma, how would you define brain trauma in your own words?
So that's a very broad concept, but at the moment,
Yeah.
most of the definition relies on is a direct injury, direct physical injury into the brain. So, and that encompasses a lot of various concepts because, that the physical injury could mean a lot, and it could be associated with various degrees of severity. The problem is that the fact that there is this primary, the direct impact into the brain that causes direct damage into the tissue of the brain per se already causes a dramatic effect into the tissue, and then this tissue needs to compensate this. No? And unfortunately, the brain is such a perfect and beautiful structure that while it's very good in doing what it does, it's a challenge sometimes for such a nice environment where it gets challenged to regenerate, to become young again, and to heal, no, and to recover from this injury. And this is what we're trying to study. So when you have a fracture, we understand that the bone has a good capacity to heal, and we have a fracture and we know how to heal a fracture. But we don't understand very well when there's a problem with the brain, particularly a traumatic problem that actually a physical injury into the brain. We're trying to understand how the complex but very important and very valuable cells that we have in the brain can and get together to actually heal the same way that ideally the bone would heal when you have a fracture. And this is the challenge when tissues are very specialized. As I said, the brain is beautiful in what it does. It's a very advanced functional organ, but sometimes the more advanced functional organs, it means that they are so protected that when they get injured, maybe they don't have the best capabilities to actually recover because their function is to do what they do best. But we normally wouldn't expect, ideally, with the brain being protected by our skull, that there is this traumatic injuries on the brain. So this is where the challenge relies.
Yes, that's a great explanation of brain trauma. It's really fascinating to think about the complexities of the brain and how intricate this organ is. And it's practically responsible for everything that we do, from thinking to feeling to sensing. And therefore, when the brain does undergo a traumatic experience, these delicate networks are disrupted, and therefore it can lead to a wide range of symptoms. So in today's episode, I really want to focus on delving further into understanding the effects of brain trauma. So what are some of the short-term and long-term effects of brain trauma, and how does this impact the quality of life of an individual struggling with a traumatic brain injury, would you say?
So the main problem in here is the huge variety of injuries and
Yeah.
the hard to understand the prognosis of this injury in the different patients. Obviously, one
Mhm.
could say it could be different in younger patients than in age humans or in a young fit adult. But it also depends on the degree of severity, the time of the time that it takes to treat this patient. So there is a lot of factors that will affect the outcome, how the patient will recover with this. But definitely there is the fact that there is an acute and unexpected effect that's unpreventable. So we have to deal with the fact that there is already an existing injury caused by the harm, by the direct impact caused by this physical, impaction onto the brain. And then the second problem that we have to face is obviously the tissue will respond with as we do, like when you have a cut, the skin inflames, so the tissue will inflame. The brain will inflame because it has different cells that can inflame, or we can get different cells from the body there to try to help to heal. But as I said, this healing process can take a long time, and the healing process is never perfect. There is
Yeah.
always effects with the healing process that can be detrimental. It is, if it persists forever. And unfortunately, the brain has limited capacity to build up a newly formed brain. It's not like the bone. The bone has a capacity, like, of the skin, that we have a cut and the skin can grow new skin or regenerate. The brain has very limited capacity for this. So we need to find a good balance of, once we know that there's an injury, how we are able to support the secondary effects of inflammation ongoing into the brain, and to support this the best way we can to reduce any further damage, and obviously the effects on behavior and cognition that will have on the patient.
Mhm. So I really like what you said about how trauma injury is not like a broken bone, which can repair after a couple of weeks, or like a cut on the skin, where skin cells are capable of rapid regeneration. And so the brain differs from this. And like you said, it's due to this limited regeneration, which is a very slow and restricted process. So, like you mentioned, after a serious injury, we have something called platelets in our body that clump together to form clots. So they seal the wound and prevent it from further bleeding. However, there is a condition called traumatic coagulopathy, which is a condition that develops after a serious brain injury, where the body has difficulty forming these blood clots. Could you maybe explain this further and how this can impact brain injuries as well?
So I have done a little bit of work with my colleagues here at the Royal London, which they are the real experts on acute coagulopathy. One of the main problems with acute coagulopathy, as you will explain, is that the system that we have in our body to deal with this blood loss, it doesn't work anymore. So if this doesn't work anymore, we don't have the ways to turn on the tap. And the fact that we can not turn on the tap has a huge effect into our body, because our blood, it's functional, it's critical for us to sustain the functional of all our body. And what happens when we have a patient that develops those conditions? So we have a patient with traumatic injury that actually then also develops, so it's one thing is linked to the other, this what we call this acute traumatic coagulopathy, and things get worse quite quickly, with the fact that the patient cannot really handle very well this blood loss. And remember that if we don't have enough blood into the system, we have less oxygenation, so we have a huge effect across the whole body, because this not only compromises the brain and the blood flow into the brain, which is critically important to bring this oxygen for the cells to actually survive, but also affects the heart, affects the lung, and affects the gut, and affects other organs. And we're talking about here organs that are vital. So if our lungs, which we know have a very thin layers of tissue, get compromised, we don't have good exchange of oxygen. So we have poor exchange of oxygen. We have poor blood circulation across the body, which doesn't help to circulate this oxygen that our body needs. The heart also gets really affected because the capacity of the heart to pump more blood and intrinsic capacity of this heart to actually do this pumping function, getting this blood across the body, this gets affected more and more and more. So you can see that we have a system where the heart is not pumping the blood. The little blood that we have is it's not very well oxygenated, and we're losing blood somewhere that we are not able to close and turn off the tap. So the situation, it's very critical, and if it's sustained for a long time, there is no way to recover it. So this is critically, and it can be very critical for patients.
Okay. So, like you mentioned, traumatic coagulopathy can be very dangerous. I like what you said about how it's like an open tap, because, of course, with this excessive bleeding, it can be very difficult to control this, and this can be very detrimental to other organs, and therefore it can be very life-threatening if not treated. So, in April 2010, Greater London implemented a trauma system called the London Major Trauma System. Could you explain what this is and how maybe this has also benefited patients?
So I am, as I said, I do collaborate with the Center for Trauma Sciences here. It's a major trauma center here at the Royal London. But I'm not part of the clinical department. But as far as I could say, though, obviously the important thing in here is to set up centers of expertise. You can understand that these patients are very complex. They're very complex scenarios when one medic cannot know it all. So it needs a great expertise from paramedics, from emergency doctors, from vascular consultants, from neurologists. So it needs a real team to work together to treat these patients. And there is also another important thing in here, which is the timing of intervention. These patients with these acute issues of bleeding, acute trauma, at the level of the brain, or acute organ trauma, it needs to be treated rapidly. The time is crucial. So having these big major trauma centers, they are all set up to deal with these very complex patients, but they have all this expertise, and they have a helicopter, they have the ambulances, they have a very good setup and network across London. It means that they can control this scenario of unpredicted trauma and then treat the patients within a reasonable amount of times the best way possible, giving the best chances of survival for these patients.
Of course, timing is very crucial when it comes to brain injuries, and this can be very, very beneficial for the patient's outcome. So, moving on, I am aware that a lot of your work also focuses on experimental models and translational research within the brain trauma. So, how do you ensure that the complexity of the experimental model is a good representation of the real world brain trauma scenarios that we face?
Yes, so this is a very good question. So I think the concept of that we do the same that it happens in humans, it's not completely true. The complexity of the clinical scenario is really, really vast, no? But if you consider that when we have a patient and we need to understand the condition, it's very limited what we can do to that patient, because that patient is already, we don't predict that that patient will have a traumatic brain injury. So we need to find ways how to understand in a living scenario that how this combination of injury in the brain and blood loss and the hormonal system, the heart, the blood, the lung, everything gets together and gets affected by this, the conjuncture of this several series of scenarios related to the pathology. So it means that there's brain injury, there's coagulopathy, there is all the affections from the breathing as well. So the modeling comes here to try to understand very specific parts of this complex jigsaw. So I wouldn't tell you that, oh, I have a model that is the same as a human. It's not this concept. What we're doing in research is, if, for example, let's say I want to understand why this coagulopathy, this blood doesn't clot. So I'm going to focus in modulating part of this very complex scenario to see why this blood doesn't clot. And then try to understand what is happening in this blood, that it's because of this injury that is stopping the blood from clotting, from actually stop bleeding. No? Once I have this information, then I can apply it to the patients, or I can apply the next study looking at different objectives. So everything we do has a very specific question, a very specific hypothesis, and it's not like we try to mimic exactly the whole scenario. We try to have very clear questions with answers that we can address. We need to be very realistic on the expectations of what we're doing. So, as I said, so we, for example, talk with blood pressure, bleeding. What I want to see is that the blood pressure, that is a good measurement, or the blood volume, it's sustained. So with my models, I'm trying to understand how this injury will affect, for example, changes on blood volume or changes on blood pressure. Similar what happens in humans. So I know that this is only a little part of the complexity what we see in the patient, but this part per se, it's very important. And by limiting and being very strategic on what we study, we have much better chances to bring meaningful and relevant results that then could help us to understand better what's going into the body of human patients.
Yes, so it is very important that there is a clear investigation, a clear hypothesis that is backed with scientific data before applying this to an animal model, and also ensuring that the well-being and the welfare of the animal is abided by. From what you've explained, I can see that a lot goes into the work prior to applying it to an animal model. So with these experimental models that you do conduct, what are the ethical considerations that you would that would need to be addressed when conducting these investigations?
Obviously, it's very important that all these complex models are addressed with a full compliance on the regulation, the current regulation in the UK, which is falls under the Home Office, but also the ethical regulatory framework under each institution, in this case, Queen Mary, where we work. So any project that is undertaken at the level of modeling has to be approved by an ethical committee, and it has to be approved by the government. In these projects, which is very important to ensure that there's a need for this, and there is a direct impact on clinical care, so that what we do will have an impact providing better care on a clinical scenario, in this case, on trauma patients. Secondly, it's very important that, as I said before, that what we're trying to do, it's feasible. So there's a clear hypothesis and a clear understanding what we will do and how this will affect the welfare of the animal. And we need to ensure that this welfare of the animal and the well-being will be supported and will prevail. So we cannot go beyond the severity that is being approved by the regulators, in this case the government, but also the ethical committee. It's very important also to understand that we don't go and jump directly into, for example, an in vivo model. We first of all try to understand the condition from patients. We get a lot of clinical data from patients, a lot of diagnostic data from patients to understand the condition better. And only when we have a specific question with a clear hypothesis, some of this work can be done at cellular level, taking blood from patients, taking cells from patients, or having cells that can be cultured in the lab. But sometimes in this complex question, we need an organism that have a cardiovascular system. So we have a heart and the blood is pumping within a system that has a brain. So it's very important that we have this dual scenario when we have a central nervous system. So we have the brain, we have a spine, we have the nerves, but then we have also a heart and vessels, and all this gets together and interacts together when it gets challenged by traumatic injury.
Yeah, it's very important that we consider the ethical implications of animal research. While animal models have a place in research, especially in trauma science, it's important to consider the animal's welfare. So, what would you say is the biggest challenges in translating this experimental findings into clinical practices then?
I think the major challenge here is to ensure that you have a very clear hypothesis and there's a clear expectation on the clinical need. I think jumping into something without understanding the clinical scenario and the clinical need, it's very faulty. So that's why here in the Queen Mary and the Royal London, the strategy is totally appropriate, because the setup they have here in the Major Trauma Center is they have a very full understanding and comprehensive data from trauma patients. So this data allows to understand a lot the pathology that develops with this traumatic injury, slash also linked to coagulopathy and these blood clotting problems. And this is really important then to understand the condition and to see which areas research is required with direct impact into the benefit of the benefit of these patients exposed to trauma. This understanding sets up the clear question, hopefully, for them to progress into the necessary research needs. So it's very important that anything that is done is well contextualized within the clinical need, and there's a clear understanding of the impact that these outcomes will have onto the research, and very importantly, to assess, obviously, what we're going to do in these models with the impact that we're going to get from these studies, but very importantly, how this is going to impact on the welfare of the animal, because there needs to be a trade. We cannot do things that will harm the animal or the in vivo model. So it's very important there's an appropriate trade, an appropriate what we call the harm-benefit balance to ensure that these expectations are well balanced at the cost of having a good impact on the care and the welfare both of the animals and the clinical patients that will benefit from these discoveries.
I see. So ultimately, a combination of animal research, clinical trials, and real-world data is essential to develop effective therapies. So I'm also aware that you do some research that looks into biomarkers. Would you be able to explain what biomarkers are and what are some promising novel biomarkers for brain trauma that you may have been investigating that could potentially help to improve early diagnoses and maybe treatments as well?
So so a biomarker is any kind of readout, something that will give you a clue of what's happening into the body. It's as simple as that. Obviously, the idea of a biomarker is something that can be quantifiable, that it gives you a clear clue, without doubt, something that can be measured, something that can be easily obtained. So blood sample, saliva, urine, of skin, something that you can take without causing any harm into the patient, but will tell you a lot of what's going on inside the patient. So in this case, taking a blood sample or a urine sample can be very useful. But another approach to do this is actually looking inside the body. And so we've done a lot of work with imaging. So like, you have an X-ray, or you have an ultrasound, or you have a magnetic, an MRI that everybody knows what MRI is, to look inside the body. So we've done a lot of work, both inside looking at the functionality of the brain, but also at the functionality of the heart, following traumatic injury. And by doing this, using imaging modalities, which, remember that this imaging is the same that in the patients, they're not harmful, because it's a way that we can image the body without harming the body. We have been able to characterize the cardiac function, looking at the how the heart functions during trauma and following the recovery of trauma, how this cardiac function gets affected during this process of trauma and bleeding and traumatic injury. And also, from the brain perspective, we have ways to visualize this what we call this inflammatory process that goes on the brain. And remember that the brain is inside the skull. It's very, in a way, it's very robust, but it's also very fragile. And it's really difficult for us to understand what's going inside the brain without without opening the skull, which we don't want to do that. So we have developed ways that we can image, and by different significant parameters, we can understand how the cells inside the brain are responding to this traumatic injury. So we assess what we call this neuroinflammatory response that happens in the brain following injury, and we can do this longitudinally in the models that we have studied, and this have proven quite useful to monitor this progressive neuroinflammatory response onto these models, and ideally, hopefully, this also has been used in patients.
So using biomarkers and imaging provides researchers and clinicians with a better understanding of brain injury and developing a more effective treatment without harming the body. So looking ahead, what would you say excites you most about the future of research in neurotrauma and trauma sciences? And what maybe advances would you hope to see in the coming years?
I think we need to find better ways to model the condition. As you can guess, it's very challenging. It's very difficult. We do a lot. We have progressed a lot of understanding of the condition, but the problem is that when you talk about understanding the condition, which is very acute and very unpredictable, something that happens very quickly, we also have limitations of what we can do. We have progressed a lot. As I told you, we need now understanding of how the trauma affects different parts of the body. But the problem is also how this then can be translated into the patients. As you know, bringing something into patients needs to have a safety and efficacy control. So we cannot do something into the patient directly. So it needs to have what we call this clinical trials, a trial episodes that goes into the patients. This is quite challenging and the setup of trauma sciences, because you need to have a huge amount of resources to support this. And this, unfortunately, with anything else, it's challenging to put more money into trauma sciences. We need more money into trauma sciences, but it's challenging because it actually requires a big infrastructure, and we need more clinical trials to support these developments. And secondly, because you can see that it's a multidisciplinary approach, we need also to work closely to improve both sides, the clinical, the information that we can get with the patients, because the cohorts are very varied, very huge populations, but to trying to get more information from these patients using more novel biomarkers to understand better what's going with these conditions, and then try to target better how we investigate these resources. One of the main problems that we have with, for example, with how the organs gets affected with a traumatic injury is that there is a very quick switch of functionality into these organs, and then sometimes to the point that they cannot be salvaged anymore. So things can go badly very quickly into these patients, and time is of essence. And to understand how we can do things quicker, it's always a challenge, because as you can see, there is a lot of unpredictability factors, getting a patient much faster to the major trauma centers, getting better ways to assess the prognosis of the patients, getting better ways to intervene the patient, getting better ways to understand how we can support all these very challenging problems into the patients. It needs further research. So I would say it really needs a conjuncture support with finances, better funding, and continue working across multidisciplinary teams to bring together all this expertise for the purpose to build up better therapeutic approaches for trauma patients.
Yeah, I do believe that the future of trauma science, there is a lot that needs to be worked on in the sense of funding, like you mentioned. But I believe that if we continue to do what we're doing and the advancements, I believe that the advancements have great potential in enhancing diagnosis and treatments and ultimately improving the patient's outcome. So this concludes episode 2. Thank you so much, Dr. Jordi, for joining us today, and I really hope the viewers found today's episode very insightful. Stay tuned for our next episode, where we'll be discussing the brain's protective agents with Dr. Ping Ye.